We are on the sidelines of the first World Congress on Cardiometabolic Medicine, and I have the pleasure in welcoming Dr. Vivek Gupta, who is Professor and Senior Interventional Cardiologist at the Apollo Hospitals in Delhi. Welcome, Dr. Vivek Gupta. Vivek, we've been hearing so much in the last 2 months, the buzz in the air with the publication of the Partner 3 trial and the Evaluate Pro trials. So what is your take on the current state of TAVI in this spectrum of aortic stenosis?
Thank you very much for asking this question. You know, TAVI is now established technique, which is transcatheter aortic valve implantation. Europeans call it TAVI, which is implantation. Americans call it TAVR, which is transcatheter aortic valve replacement. Actually, it is not a replacement, it is an implantation. And before I go on to the TAVI and other treatment, I would like to give a small introduction of the aortic stenosis. We know that for the interest of the audience that we have a heart has 4 valves, and the aortic valve is one of the very important valve which get diseased over a period of years, and the most important cause of aortic stenosis is degenerative aortic valve stenosis, which is more common in the elderly population, especially in the Western as well as the rising age in the American population. Of course, we also have in India, we have a rheumatic heart disease, which is associated with mitral as well as most commonly aortic, and both together. We are not talking of that. We are talking of degenerative aortic valve stenosis, which is because of degeneration over the years of age, the aortic valve gets stenosed, and it leads to syncope, angina, and other sometimes risk of sudden cardiac death. And this is, as a surgeon, you know, Dr. O.P. Yadav is a very important surgeon of the country. He has been operating such patients for a long time with open heart surgery and valve replacement, which has been a standard of care for several decades. But with the aging population, with the comorbidities, many times they become higher risk, especially if the patient is having a post-bypass status, or patient is having an associated nephropathy or a COPD or lung disease. Such patients become a little high risk for the surgical aortic valve replacement. And when I had the privilege, let me introduce myself, I had the privilege of working with Professor Alan Crebier way back in 1996, 97, 98, when he's the father of TAVI, actually, we all know that. When he was in the idea of conception, that he was that how can we change the valve, or we can have another valve without opening the chest. Transcatheter aortic valve replacement or implantation is actually a technique with the help of a large catheter through the groin. The valve is inserted into the heart without opening the chest, and of course the patient risk is little low as compared to the surgical valve replacement. So earlier when it was introduced, the first case was done in April 16, 2002 by Professor Alan Crebier in France. At that time it was one of the most revolutionary technique considered to be, because the first case is always very important. That was a case of a patient who was 57-year-old, post-bypass surgery, low ejection fraction, and the patient was refused by the surgeons for the aortic valve surgery and replacement. So that was a time of important thing, and since 2002 to today, 2019, there have been several trials all over the world, especially in Europe, and of course later on with the one thing very interesting which I would like to share with the surgeons, as a surgeon like you as well as with the audience, that when Dr. Crebier was having the concept, he went to the companies, and one of the important company was Edward Company, which was making a surgical valve. And Edward Company had completely refused the idea. He said, I will not take up this case. This is something which is non-imaginary. This is something which is hypothetical. This is something which is madness. This is what the word used on the writing. And then they had a concept with, he worked with Martin Leon in USA, and they made another company, and through which they developed this valve, and they had the first valve in April 16, 2002. And then the same company, Edwards, you know, is the leading brand. Once it was getting established, they bought the whole company which was being developed by Alan Crebier and Martin Leon. And then, of course, you know, the Sapien 3 valve and other valve is now Edwards valve. So earlier it was known as Crebier valve. Later on it changed to the name of Edward valve. So the concept has already evolved. There have been trials used. Earlier it was approved only in Europe. Later, with the partner trial, it was also FDA got approved, and there was a revolution because in America, such cases started developing.
So this Can we be a little more focused, Dr. Vivek? Now, we were talking of the current status. We know that it is well established for high-risk cases. What is its role in low risk surgical
You
cases.
see, with the partner, I would like to give you introduction again with the partner 1 and partner 2, and then I will take on to the partner 3 trial. So when it was FDA approved in USA, there were trial comparing the surgical aortic valve replacement versus the transcatheter aortic valve replacement, which is a non-surgical. And the partner in partner 1 and partner 2, which was, of course, Martin Leon was involved with Alan Krieger and other patients, but to the multicentric trial, they confirmed the non-inferiority of the TAVI as compared to surgical valve replacement. Of course, when the technique is getting evolved, you have to compare and show the non-inferiority and then later on superiority of the technique, but that was only the high-risk cases in partner 1 and partner 2 and also the moderate risk cases, and those cases which were considered high risk and not amenable to a surgical valve replacement. So that was a very important part. That was 2012, and then 2011 New England Journal of Medicine, it was established, it got established, and then further. SAPIEN 3 is a low risk and medium risk cases also they have encountered, and they found, I would say it is non-inferiority plus a little superiority as far as the death in a few 3 years or 5 years to that trial, and sooner or later the low risk degenerative aortic valve stenosis, which can be done by a surgery as well as can be done by a transcatheter technique, will also become a routine practice. But at the same time, as we all practice in India, the cost of the treatment becomes sometimes a deterrent in taking one procedure versus other procedure. You have been doing cardiac surgery. In a low risk cases, you will always prefer to do a surgery because it is comparable, but it may be a little superior also as far as the death rate and mortality is concerned and overall. But at the same time, the cost, as you know, I would like to share with the audience, the cost of the valve, the transcatheter valve is of almost 4 times as compared to or 5 times in India, and where the insurance is not covering too much. And in fact, central government health services patients are also not covered as far as I know. And therefore, if the patient is treatable with both the techniques, then of course, the affordability of the patient will decide whether he was going to like to open heart surgery, surgical aortic valve replacement, or transcatheter technique, which is a non-surgical technique.
Is it just affordability? If you look at India, we are, transposing all Western data to India. If you look at the mean age of the partner 3 trial, it was 71 years. The Evolute Pro trial, the mean age was 74 years. Now in India, the main indication for aortic valve replacement is rheumatic heart disease, and the mean age is 22.8 years. Now, what is your take on using a bioprosthesis in a 22-year-old rheumatic patient?
It's a difficult question to answer, but before for the interest of audience, again, let me introduce that Evolute trial is a Medtronic trial, which is for the core valve. There are 2 types of valve available. One is self-expanding valve, which is a core valve, which was at the same time when Krieger was doing and Edward was doing, that is a balloon expandable valve, which is like a stent technology. It's very important for the people who will listen to it. So the Edward valve is a balloon expandable valve where there's a balloon and the stent is over it, and when you inflate the balloon like a stent, it goes up and the valve gets deployed. You have to be very, very precise in finding the location because you cannot pull back. At the same time, when Dr. Krieger was doing, there was another company, like core company, which started developing a valve which was a self-expanding valve, like a valve stent. Valve stent were there, which was self-expanding stent, although they are not being used now at all. So this Evolute is then the company Medtronic took over the core, and now Medtronic is selling all over the world, which is the core valve, now which is Evolute valve, and they have done a trial in a less risk person, partner 3 and this Evolute Pro trial.
Evolute Pro.
Both are almost the same kind of patient where they have taken a medium risk as well as low risk patients. Your question is very different because in our Indian scenario or Southeast Asian scenario, we have much more larger population of the rheumatic heart disease, where younger patients are getting affected with aortic stenosis. Such cases have not been at all being discussed or have a trial with this. But at the same time, it's very important that these valve deployment depends upon the calcification. If there is a huge calcification, then Edward valve will stay, and similarly for the valve which is a core valve or Evolute valve will stay. So in a younger population, where rheumatic heart disease in India, where even it is isolated aortic stenosis, which is not such common because you have either aortic regurgitation or a mitral disease, I would say this technology is still not to be offered for a young population, especially rheumatic heart disease, because there is hardly any calcium and the technology will fail. So it is still limited to the degenerative aortic valve stenosis, which is in elderly population. And you are right that 71 years was the mean age in almost the same in both the group, where they have offered for the low risk patients for the aortic valve stenosis. To summarize again, for the rheumatic young population, surgical valve replacement is still the only answer. This technology will work only in elderly population, or you have an elderly rheumatic heart where you have a little, at least moderate calcification present around the aortic valve, which will help the anchoring of the valve in the aortic area, because you're not suturing it. We are doing it percutaneously without opening the chest, and therefore it is very important that these patients, young patients, cannot be treated by this, as far as my knowledge goes. What is your take on that?
Yeah, I mean, that's what I'm saying, and the audience must get that the TAVI is still an option only for elderly patients,
Right.
and it's a mechanical valve which is suited for the younger population. So it's not that with the advent of TAVI that the mechanical surgical AVR has gone into oblivion.
For the rheumatic, of course, you are the boss.
Now, for TAVI, we find that the incidence of
Stroke,
permanent heart blocks and PPI is very high. So are there any iterations which are there in the offing to reduce this?
This is again a very important question. You see the atrioventricular block, which is AV block, can happen in both Edwards, which is a balloon expandable valve, as well as in core valves, but the incidence is much higher, I would say. It is about around 20% in cases of core valve or evolute valve, which is a self-expanding, as compared to which is about 5 to 8% in cases of Edward valve. I have so these patients will require a permanent pacemaker during the same time of hospitalization if they have the complete heart blockage, which is a part and parcel of one of the complications, which is treatable complication. It's not that it's a life-threatening complication. You take it and you find that the patient has had a complete heart block, you implant a pacemaker, which is again a percutaneous technique, and then for the patient can be discharged with a permanent, with a valve as well as with a permanent pacemaker. I do not have any idea, actually, to be very honest with you, that any such technology which is going to reduce the pacemaker, because you see that while we are implanting the valve, there's a atrioventricular fibers are going on. So this is going to stay, I think, and you have to accept that. You have to tell the patient from the beginning that you may require a permanent pacemaker. And I told you the Edward valve has a much lesser risk of having a permanent pacemaker requirement as compared to the evolute technique, which is core valve. And in India, unfortunately or fortunately, whatever, the Medtronic core valve has had larger experience because they brought it into the Indian market with the registry, and now it is available on the shelf. At the same time, the Edward company is still having a few selected centers. They are a little more cautious. They still need a mentor to come along with the procedure operator, and therefore although a number of valve all over the world, Edwards is more as compared to core valve.
So, well, ladies and gentlemen, you just heard a percutaneous option to aortic valve replacement is a reality. It's a wonderful development, and for high-risk cases or for young patients, mechanical valve stays as the primary option, but for elderly patients, even if they are low risk for surgical aortic valve replacement, I think TAVI is going to be the future. Thank you very much, Vivek, for joining us.
Pleasure talking to you, sir.
Yeah.